Good morning, everyone. So my name is Dan Zhao. I'm one of the pediatric rheumatologists at Seattle Children's Hospital, director of the CRMO program. On behalf of our rheumatology division CRMO program, just welcome all of you who are here in person and also those who are joining us online. First of all, I would like to start with a thank you list. Susan Thornhill, Nancy Hardwick, and Ava Klein have put a lot of their time, heart, and soul into planning this event. So let's give them all a round of applause for all of their hard work. And also all the volunteers from Seattle Children's Hospital and from the qualitative research community and from our team and also parents and families. We want to thank you all, and also our AV team here today, catering, the marketing team, students, and everyone who has been involved. And without all of your hard work, it won't happen. So thank you. So today, here's the agenda. As you see, we have a fairly packed agenda here. The first 45 minutes, we're going to start with some opening remarks. I'll give a short talk on research update, followed by Susan's instructions on how to do the breakout room sessions. And really our goal here today is for all the families to feel connected and feel heard. And we can pass your voices into the rest of the community. So I will start with my research talk here. So here's my disclosure. And since you all are going to share your stories, so I have to tell the story here as well. As my kids may tell you, I'm a terrible storyteller, but it does not stop me from trying. So one day, thinking about a kingdom and their military force rebelled. Now, instead of defending its people, he started attacking. Now, also these attackers are disguised, so it's not easily identified. So you need to give the shields and to protect the people, or you got to do some investigation and identify those attackers and correct them or remove them. And then people are safe again. And so what does that story have anything to do with CRMO? Well, think of that military force as your immune system, and that kingdom is your body. And then the people is your healthy bones all over your body. Now that disguised little immune system now got sunglasses and you can't see his face. Now that shield could be the medicine or other therapies, and that can protect your bones. And by taking out the ones that are doing the bad things. And then your bones are happy. And forgive my terrible drawing, and not as good, and make it look like a little snowman. So remember these themes in your head as we're walking through. So first, if we are going to try to address CRMO, if we're going to try to bring the bones back to the happiness, and we have to do some investigative work in each one of the child who's suffering those. Now, what kind of things we need to do? We need to ask, who are the disguised attackers, right? And why did they turn bad? And a lot of work has been done by Dr. Polly Ferguson, my mentor at Iowa. And thanks to her team's relentless efforts on pursuing, there has been many of the genes identified, but these are a very small portion and they tend to affect kids who are younger. So the majority of our patients do not have one single gene causing those, but we should still continue that genetic analysis. It may be a group of genes, and then we will be able to tell our families better. So what are the other ways? We have collected hundreds, if not thousands, sets of the blood samples from our patients. And we are able to use that, a small portion of those, and to do high throughput. So that means you can look for multiple labels or features of these disguised attackers. Or we want to find out within the immune system which part could be different in the kids' blood who are currently being affected by CRMO comparing to the healthy kids. That's on the left column here. And on the right side is when they're doing better. Do they change? So what you want to find is the things that is changing. Now it doesn't tell you it's the chicken or egg. Do they happen before, they happen after? No, but it can tell you it may be potentially used as a marker. So it's important work. And of course, these tests are not cheap. So that's why we only did a small, and the goal is to secure the funding and to do it on a larger scale. And also to test across the different diseases. Is that special for CRMO, or that is across arthritis or other things? And more detective work needs to be done. You got to go to the source. Is looking at the blood, maybe one bone, the things that will stay inside. It's just in the region, and then the rest of the region in the kingdom doesn't know about it, so it doesn't get spread. So you got to go into the spot where the problem is. Now, there are three kinds of diseases. You see these bone tissue line up here, and this is the bone that is being attacked by all these cells, and these are disguised attackers. And then the other two diseases, this is cancer, this is the infection. And why do we want to compare across? Because right now we still don't have any specific marker. Now, the question is, are the inflammation you're seeing in CNO, CRMO, the same as the other two? Now, we think they may be different, or maybe different stages, but that will give us more clue. So thanks to Kayla Comfort for supporting that work, and in collaboration with Vanderbilt to Dr. Cassette's lab, as well as Paula Ferguson. So we're hoping to get some results in the near future. So now we're going to shift the gear to the protective work. Well, we're trying to figure out the investigation, which can take months, years, or even longer, right? But that work needs to continue. The people need to be protected at the same time. So how can we do that while waiting to know the true answer? What had started at the first place? So what shields are the most effective? These are the questions. You see all kinds of pills. Which pill is better? So that comes along with a choir, not for you just to sing, but also for us to collect the data. So that stands for Chronic Non-Bacterial Osteomyelitis International Registry. And the information is collected from routine visits. But you may wonder why Dr. Zhao, Dr. Rosenwalter asked me all these questions, because we want to have more comprehensive information other than just feel your limbs and then show the images and give you a prescription. So that probably is not going to carry us very far to identify the answer we are looking for. So which one, Aleve or biologic or permissione, which one works better? And what is the goal? You have to have enough of the patients, the big data, in order to conclude, because we all have the differences in how you adjust the medications. Only the number will allow you to have enough patients within each. So who can participate? Anyone who's under 19, diagnosed with CRMO, and continue to follow with a clinical care at one of the sites. So we want to ask which shield is more effective, and also if it is effective, is it safe for you to remove that? And all the things that disguised bad attackers are gone in your kingdom. And also, is that shield have too much weight? It's going to hurt your back. You're going to have another problem. Or it is someone is sighing, or it is going to carry you stronger. So you develop more strength while you're wearing that shield. And how do we know it works? Everybody have a different standard. And one doctor said this, or you may say differently. So far, we have 300 more patients across 15 sites, including 7 international sites, as you can see on the map, across most of the continents. And we finally got our first manuscript published online. So if you go to Google, just type in the title, you should be able to view the entire manuscript. And that is our goal from here on, that we should make the results available to our patients at the beginning, because the review process usually takes 1 year and there is a significant delay. So how do you, what kind of shields, and how do you decide in when to give this shield than the other? So this is the standard that majority of physicians in the world have been following. If a patient has been diagnosed with CNO or CRMO without Crohn's disease, ulcerative colitis, then we need to find out, do they have any spots that make you concerned the spine is going to collapse or not? Because if they do, you don't put them on the NSAID trial, Aleve. You got to move them to the fast track and start with effective treatments. And if they do, they go down this path, then there are two major treatments that have been proven to be more effective than the rest. The biologics such as Humira, infliximab, or the permanganate, the infusion. For the patients who didn't have the spinal lesions, they will all get a trial with Aleve type of medicine. If the physician and family think it's working, then they will be going on with the treatment for a different period of time. And that is hugely varying across different centers. As I'm learning, coordinating all these meetings, my Colorado colleagues will do a 6-month, and I used to do 2 years. And that's a huge difference in who is right. Or maybe we're both right on some cases, and we're wrong on some other cases. And these are the information and the questions we need to ask ourselves and need to address those. So that leads us to the effort. How do we decide the kid is responsive or not? And we needed group participation, not only the physicians, but also the patients and families. So we'll get together at a round table. It was a virtual in 2021. And the key questions are children's complaints important? And is MRI important? The tricky thing is they don't always go hand in hand. And what do you do? And as you can see, all the group members and had a great and happy discussion, having smiles on their face. And we decided as a group that we need to anchor our assessment based on how kids feel first. So this way we can put our step forward. Otherwise, we'll be spinning in circles. And we always will argue which one is more accurate. But once we have an anchor, we can assess how does the MRI, and we can dived in deeper. What features in the MRI is truly concerning, what is not. And so, but we will continue to collect MRI. And in clinical care, we do need MRI to help us. And but it's not the main research tool at the moment. In the clinical trial, will needs to based on the patient's complaints. And that will get us to someday with approved medication. So what are the components? And we ask you, how much pain do you have? And how does it affect your life in general? You're still dealing with this disease. And we will push on different parts of your body. And if you say owie, and if we detect there is a temperature increase, it's hot, it's warm, or it is swollen, so we will jot down one count, and we add all these together. And when we compare the total number, the sum score, before the treatment and after treatment, and we saw the decrease. And why is this important? Because whenever you design a clinical trial, you can't just go to the FDA, to the company and say, well, I want to do this. I think 100 will be enough. You have to prove with your data. Why do you think it's enough? And with that, a predetermined sample size, then you're legit, you're looking for something that is answerable. Otherwise, it comes out of air and it's not going to be reliable. Nobody is going to say it is working or not working. And it also, the score, as you can see, it correlates with how our children are thinking. We ask the question differently. Do you think it affects you a lot, a little, or somewhere in between? Or it doesn't affect you at all because it's completely quiet. Your people are safe now. Your bones are healthy. And that score totally correlates. So it proved it's validated. So then the question we're asking between these two most effective currently available treatments for our children who failed a leave type of medicine, which is better? And this will take a longer time because it's a smaller population, and also we have different schedule for those treatments. So we are applying the federal funding for this. And also, how safe are these shields, right? So over the 2 years, we identified the number one as the psoriasis, the new onset of psoriasis, and some developed on a medication called leflunomide or Areva. The other is on adalimumab or infliximab. And we did show the proof that methotrexate can reduce that risk. So it's important not only keep the biologic working, but also reduce the risk of psoriasis. The other severe side effects, such as, well, we don't even know that type 1 diabetes was related or was going to happen regardless. The herpes is one kind of infection, pretty painful, and bacteremia, so the germs in the blood, or new spine fracture, it occurred in a smaller, just one case in each. And these added up together is 600, 700 patient years, which means one person has been observed 700 years, or 700 patients have been observed 1 year, right? And in the big data set, and you want to see 10,000, then you will have the full confidence we're really not missing anything. So it's well represented. What about MRI? Are we going to forget about that? But in the suitcase, no. So you're going to continue to do those. Here's the whole body MRI. All the arrows are pointing towards where there's inflammation. And we have already designed this scoring tool, and these will be consistently done in our research field as we're anchoring how we assess the shield is working using how kids are telling us. We're also assessing how the MRI, and then we can parse it out. Is it because you have more soft tissue? Your neighbors are unhappy. That is important. Or because have been beating up, there is a mark in there, and that's important, right? That will be we call it bony expansion. And also the future AI work that we can teach the computer. All you need to do is tell the computer, you think this is quiet, or this is still being causing problem in the kids. And then the computer will generate some of the algorithms to identify those. And also the treatment, how long should you treat, as we're talking about. So we look at this preliminary data on the green dots are the shorter duration, so between 0 to 6 months with a leave type of medicine. And then the pink orange one will be the longer course. And then the y-axis, everybody's starting, this is the starting point. You stopped the medication and you start the clock. And 100% had been doing fine, right? But then it separates. The ones who have been treated longer seem to remain well for majority of the patients as time goes on, while the other seems to be kind of slipping off. And this is really small, so that's one of the other aim in our grants to be submitted. And we are right now enrolling all the patients. So even patients who didn't need more than a leave, it will be important for us to answer this question too. Now, could the same thing happen to the kids who needed homogeneous biologic? And that will be the question we need to answer after this work. What is the future? Now the kingdom is restored order, and can you be guaranteed it won't happen again? We don't know, right? And in the one report from my colleague Annette Janssen in Germany, so they invited the adults who was diagnosed with CRMO as a kid, 10, 15, actually 15 years afterwards, did a whole body MRI, and then take a clinical visit. About half of these patients still have the active disease. So there's still these guys attackers in their body. And in our population, in our patients here, what did we see? So I did a cursory look, so it's not complete. that who have turned over 21 and they have graduated from our program here, about 4 to 5 years of how long they have been here. And by the time they graduate, about half of the patients still needed medication, and half don't need medication. And these have been confirmed by multiple MRIs and also clinical visits. So we definitely see the promise. We also see that the need of this for some. And we need to ask a question, can we be more smart at the beginning so we can predict and who will not, and better notify our patients. So these complications, as you all know, it can cause the leg grow unevenly or taking turns or the spine collapse. And we're partnering up with our wonderful physical therapist, Leslie, Chelsea, now Alex. And something that we didn't know before, if you don't see any active signal, there's nothing to offer. But yes, we have something to offer because the shape of the spine doesn't matter. It affects your lung function, how much air you can breathe in, the strength and all that, all these. So there is a therapy we can provide. And then they can, as you can see, the spine has opened up by 4 degrees after 6 months of the PT. And how can we screen kids better? Before there's a problem, or before officially label there is a problem. Let's put it that way, because there is a problem. Just the problem was covered or was not identified. We need to educate more practitioners and also the community. And a lot of times from the general community, if you toss a term to your physician who doesn't know, probably it'll be their responsibility to look that up. And I can tell you there are thousands of diseases I don't know, but if I heard from my patient, I need to look it up. So your doctors will do the same. And also the PT evaluation is important. And probably we need to do more MRI and how we can lower that threshold. And maybe I'll turn to imaging. And here is one study we published using the thermal imaging. As many of you have participated, and the kids are having fun posing as a model. So is that any use to us? So Joey is the medical student and who took more initiative on this. He has been analyzing all the images were collected and compared to the MRI readings using a relative temperature. But it seems so far sample size is pretty small and we just need more data. If there is inflammation or in the near end or far end of the shin bone, that absolute temperature seems to be higher. And also we can use AI technique to help. And maybe it's not just this way we analyze, but there could be a smarter way the computer can decide there is a region it seems to be hotter and can help us. So these are some of the future research field or directions. I think all of these that we're doing will not happen without the participation of all of our families and patients, and also the funding. And funding is a limiting factor because the more funding can allow us to do this much faster pace. And so I want to acknowledge the entire group and from Seattle Children's and also worldwide, our biostatistician, and also CRMO Warriors Guild and CNO Conference, and we're collaborating with all this. So I'll pause here and see if you all have any questions. I think I have maybe 2 minutes, 5 minutes. Okay, Nancy is the boss. Oh, no, sorry, Susan is the boss. Any questions from the audience here? You can use the mic. Maybe I'll have Susan pass the mic to the people. And then Ava, if there are any questions online, you can.
Anyone? Okay.
I'm wondering if you recommend that all the kids get a physical therapy evaluation.
That's a great question. That wasn't in our radar. And once we talked to Leslie, and that become clear that we should have all the newly diagnosed kids at least one baseline assessment. and then she can help us, their team, the PT team can help us decide. So we will group them into three categories. One will be you probably don't need the intense visit and you can just follow up as needed, or the other, you need to come every time when you see the physician. So we can coordinate those. And then the third will be you need very intense assessments weekly or monthly or whatever that is. Yes, I think the answer is every kid should be. Great question.
I was wondering if there's anything in your protocols or outcomes that looks at the age of onset and outcome, because some kids start earlier and some kids start later.
That's also a great question. We didn't have enough data to look at that outcome. I assume you're referring to the 21, over 21 when they grow into the adults. So with only, I don't remember the detailed number. Let's go back. Yes, 15. Every time if we want to look for which factor, so if you want to look at one factor, you need 10. If you want to look at two factors, you need 20. So you add up to those. But that will be one thing we're hoping this choir registry will inform us. My personal experience, yes, I think some of the kids who started younger, 4 or 5, if they have multiple spots in their body that are affected, and they could have harder course or needed more medications.
Okay, I should know the answer to this one, but what happens when a pediatric patient moves out, if they're in the choir registry and they move out of the center? How do you follow their data? If you're taking up to the age 19, how do you follow their data if they're no longer in a center?
Yes, that's a great question, Libby. So there are two ways. Number one, I think it's the continuation of choir. So we need to set it up. For Seattle side, that Dr. Jenna Thompson from UW has been partnering with us and receiving continuing care for most of our adult patients. And we're in one system, so we can easily get the regulatory approval. And we just need to get funding for her team to be able to record the data as we do as well. For the other parts of the world, it can be tricky because the majority of adult rheumatologists are not as comfortable or familiar with this condition. They don't have the whole body MRI set up in their institution. I think they will take more efforts from our colleagues. But Dr. Alex from Iowa, who's mentored by Dr. Polly Ferguson, is adult rheumatologist. So he has set up a registry which collects the data just through the online, and it allows anybody to participate directly without you don't have to be an Iowa patient. So I think that could be another way, and how we can connect the two database together is what we need to work on next step.
Is his registry closing though? Because Alex Leonard in Iowa, he's working with adult patients and trying to register their data. But will that close? I thought that his wasn't just open for a small amount of time, or will it stay open?
Oh yeah. So his study should remain open for a very long time, because it's also he will need thousands of cases in order to make meaningful findings. He'll be presenting 2 abstracts from that in a week at an annual conference. So I'm one of the co-authors, but I think that will bring us more information. I don't know, one last question. Ava, is there any question online? No, okay. All right, yes, maybe a quick one.
So when we began this journey with you 4 years ago, it was very new, like there weren't a lot of people, and it was like an ultra rare. And now I think you guys are continuing to identify more people, and I even see a pathway on there for folks with IBD. So as you're gaining more data, do you think this will help kind of solidify for payers why if a child who has IBD presents with bone pain,
Mhm.
instead of continuing to call it something tied to arthritis and enthesitis to look, I mean, I think, we had 4 years of that before CRMO was identified. So do you think it will start to trigger for insurance to maybe approve
Mhm.
MRIs and things like that? Is that what your hope is with the data?
That's a wonderful question, Marcy. And I've been talking to my GI colleagues all the time, and I wrote a proposal. And I think what we need to do is to